time constraints that I should be sensitive to. Golly, okay, the wacko calls are coming in already. Brent Myers, how are you doing? Okay, and if you want, you may have you talk about the paper you had. Did we talk about that before? I had your article accepted into Annals, right? May want you to give us a kind of a quick rundown on that, if you don't mind. All right. So let's see what else. All right, let's go. So my name is Paul Pepe, and I approved this message, right? I am Paul Pepe. I'm reporting you to from West Palm Beach, Florida, where I am working out with the fire departments here and over in the town of Palm Beach, and also Palm Beach County Fire Rescue, representing Dr. Ken Shepke, and opening the meeting of the jurisdictional medical directors of the metropolitan areas from around the world, particularly across the United States, the so-called gathering of eagles as we get here together again. And so I'm going to go ahead and proceed with a couple of reports from around the planet. Sandy, we haven't heard from you and the American College of Emergency Physicians for a while, but you've been busy, not only on a personal front, but also on the professional front. You want to give us a quick report from your end?
Yeah, as most of you know, I got affected by the Texas weather. I am celebrating my first full week of having all utilities on. It was kind of a whack-a-mole. And I get heat, then it would leave, and then I get water, then it would leave, etc. And did some damage to the house. But we are on the mend, and I'm back in the saddle. ASAP has been extremely busy during this time. Shows that they can work without me. And I just want to mention a few things. On the vaccine front, we have a vaccine toolkit which we continually update. We have a webinar that I believe is upcoming, and I believe I don't see him on here. David is going to be on there with yeah, there you go, Dave. From are you on that webinar?
Which David are you talking to?
David Miramontes.
We'll see.
He's talking, but he's on mute.
Dr. Winkler is managing that because he is the director of the RIC.
Okay.
He's all over it.
Yeah, yep. So we're talking about some of the ways of handling some of the different vaccines and some of the different delivery of monoclonals. So those webinars are upcoming. I will let you know when they are there. We got a lot of resources coming out about well-being. I'm going to put in the chat our data visualization. We've got data from the CDC, which we are posting that looks at ED visits, as well as COVID and influenza-like illness. The ones we don't have, obviously EMS runs, but I think the ED visits will give you some idea of what's happening. You can break it down regionally, nationally, by the last 7 weeks, the last year, etc. And then the other one I wanted to mention, so we've been working with some people who are in the Biden administration, and there's a lot of interest right now in looking at vaccine sites using the ED and potentially other sites associated, for example, with EMS, and there may be some funding with that. That's just to sort of whet your appetite. I haven't heard more about that, but I know that there's some interest in that. But again, ASAP is here to help you. And if you have other ideas of things that we can do, please let me know. That's an abbreviated report.
Okay, good. So anybody else have anything to add to that along those lines, or want to ask her any questions? If not, then I will want to move over to some people who are short on time. And that's one person will be Scott Gilmore, who's always, again, Scott, you may not know, is always deep background, looking out for us, long-term planning, and making sure that our future meetings are going to be taking place. And he's established a lot of the relationships that we're going to partner down in South Florida with the First There, First Care conference. And so as far as we're concerned right now, we're still tentatively planning and still getting together. Even if the conference falls together, I'm hoping we can still all gather for a little while with our Eagle Creek approach. So, and then maybe I'll take some time off and go do some partying down here in Florida if you got some extra time after that. So with that, Scott, anything to report, one from St. Louis and two about the possible, the likely, hopefully, conference that we will have?
So let's start off with the conference. It continues to undergo its planning. It's a great group to work with the Fire Chiefs Association and everybody associated with that. They're all excited about trying to put on an in-person conference as well. So hopefully everything will be a go from that. Still working through some of the details, and we'll get those to you as soon as we have those hammered out. As far as St. Louis, really nothing more to report than what everybody else is experiencing pretty much within their own cities.
Okay, good. Well, fantastic. Thanks for being to the point, and as usual, great. And thank you for the efforts you're doing. Again, this is the unsung hero behind the scenes doing everything for us. So thank you so much, Scott. You're fantastic. So, all right, so let's move on. I think AJ, just let me see what this is. Go ahead. What is your emergency?
Hey, this is Michael. Sorry.
Oh, Mike, I'm on the Eagles call right now. Okay, can I call you back in about an hour and a half? Is that okay?
I'll be in a meeting then, actually,
Okay.
but I just wanted to say I got the shot.
Okay, good.
Have fun.
Okay, we'll talk later because I'll tell you what symptoms you're going to
Bye.
get. See you later. Bye-bye. Sorry, buddy. That was my son. That's why I took the call. So he got a shot. So I'm excited for him. So it's good. All right. So let's see. AJ, you have to get off pretty soon, right at the top of the hour. So anything to report from your end? Anything we should know about? AJ Heitman.
Yeah, I'm on. Can you hear me?
Yeah. Now I can hear you. Go ahead.
I'm going to be leaving to talk to a colleague of Dr. Entevi's who's developed, as you may know, Paul, a really nice mask that can give aerosolized medicine without any leakage. And I think that's a big breakthrough. So I'll report back to you after I interview him at 9.
Okay, good. And then are you going to come back onto the call or after you do the interview, or are you going to do it next week? You want to report on it, or what are you thinking?
Yeah, no, I'll do it next week.
Okay, good. Okay, sounds great. Remind me, please, and I'll put it on the agenda. Okay, about the mask. Okay, good. All righty. The masked man. That sounds good. Yeah, excellent. And then Peter can maybe comment on it at that time as well. Okay, so it's good.
Well, actually, before I leave, anybody can look up Safety Neb online, and you'll see a video of the demonstration.
Okay, got it. Safety Neb online. Okay, good. Maybe chat for us, put it in the chat for us. That would be really terrific if you got a link or something like that. Okay.
Will do.
So, all righty. So let's go on and let's see. I guess because of the hour, I will defer over to Dublin, and Mick, you're the only one on from Europe so far. So Mick, what's going on there? Mick Malloy in Dublin. Anything happening you could report on? Are you guys making progress? I know you've been stressed in terms of not getting enough vaccine supply up until recently.
Looks like he's on a call right now, Paul.
Oh, okay, got it. Okay, how can you tell that, by the way?
I'm just looking at the device in his hand next to his ear.
Okay, got it. Okay, good. We'll let him go. We'll come back to him. Okay, well, let's do some announcements. Josh Hartman, you're running an EMS World Spring meeting, right? It's very virtual, right? And but you're going to have some Eagles involved in the next couple of days. I think at 2:00 Eastern, if I'm correct, on both tomorrow and Thursday. Is that right?
Yeah, 2:00 tomorrow will be the ketamine panel, and we've already gotten feedback from our audience, as I'm sure you can imagine, because of all the lay press that we're reading about the usage or over usage or under usage as determined by individuals of ketamine and excited delirium. And then the Thursday talk and medical director session will be on the COVID vaccine. So 2 very interesting sessions. After we had this call last week, I went back to our folks and said the vaccine call is literally going to be hot off the press. It's probably things that we didn't talk about last week, haven't talked about this week. It'll be brand new. So we sent out a specific email about just that one area of interest for Thursday. So highlighted that as well.
Good. Yeah. So is that ketamine? That's the horse tranquilizer drug or whatever.
Oh yeah, exactly.
Exactly.
That's
All right. Hey, so listen, well, that sounds good. Well, thanks for having us on. But you were saying last week the Eagles could get on. You were going to give the people on the call here, what do you call it, free access or something? Is that right?
Yep. I just put it back in the chat again for today. Just use the code JOSH100, 3 digits, JOSH100 at www.ems worldspring.com. So when you
Okay,
register,
so you put this code in the registration and they'll get free registration with that. Okay.
That's right. Yep.
Excellent. How about me? Can I get free registration or do I have to pay?
We could
Yeah.
take a vote. We could put a
Okay.
poll.
Okay, got it. That's right. Which we're going to talk about a poll in just a second. So it's great to have you on. All right, so let's move on. And thank you so much for that report. Hey, Sarika, are you going to have to get off at noon? I just saw you joining us.
Hi, yes, I will, actually.
Okay, got it.
Might be able to hop
And
back, but-
so maybe I should pull you in now. And okay, I'll do a quick introduction. So Rob Dunn isn't on, and Rob is one of our people who got so highly appointed to everything. He was doing such a great job at the fire department. They put him in charge of the police department. Then they put him in charge of sanitation. I could go on and on. And Sarika, he's doing a great job for you there, hasn't he, over there in Detroit? So. Yeah, well, good. But what I was going to say, so Sarika works for the mayor directly. She's a senior advisor, and she doesn't look a year over 65, but I guess she's a senior advisor. And or do you advise on seniors? I'm not sure what you do, but you're the senior advisor to. It's Mike Duggan is your mayor there, if I remember correctly, right? So
That's right, yep.
okay, good. Well, I just wanted to bring you on because just as a quick example, before I go off to some other people that are going to report on what they've been doing for vaccines, and you can probably hopefully hear some of that, the reports we've had from the CDC conference. But you've had some unique thing you've done, particularly for underserved populations and people who are digitally challenged like me. And so you can tell us a little bit on about what you guys were doing there, what you feel most proud about in terms of handling the vaccine issues.
Sure, I'm happy to. So thank you so much for having me on, Dr. Pepe. I appreciate it. So here at the City of Detroit, we are vaccinating folks through a number of different means. We have a drive-through at where we're vaccinating today. We have 4,500 folks who are coming through, and folks can make appointments through a call center. So in terms of digital inclusion, we have lots of accommodations. We're also vaccinating folks with disabilities, and then our health department is doing a lot of specific outreach into the community, going directly to homeless shelters, senior apartments, mental health facilities, substance use facilities. And we've also recently launched what we're calling Senior Saturdays. So we have this weekend, we'll have 6 different church or community centers, and folks can schedule those appointments directly through our call center as well. So I'm happy to take questions. Sorry, I know that's a very high level overview, Dr. Pepe, but please let me know. We will also be releasing our demographic data in terms of the race of Detroiters who are vaccinating and the race of doses we've administered overall, just later today, actually, on our public dashboard. So happy to put that link in the chat for folks.
So we know that people that are in nursing homes, we have a target place we could go to and deliver the vaccine to them, but it's the people that are living at home or sometimes even living alone that are, we worry about because we have to go out and find them. And what have you done to sort of track people down? Are you using Medicare? Are you using, whatever, Meals on Wheels, or what are some of the things you're doing to target the people besides saying, living in a, people where they live.
Yeah, absolutely. So we've really tapped into the faith-based communities here. So we have a couple folks in the cities who work really closely with our faith-based communities and have had flyers out at Sunday services. We've also implemented a Good Neighbor program where folks who are 55 years old can drive a senior who's over 60 to come get their vaccine. And that's how we've had even folks in the suburbs who are willing to drive a Detroit resident, and they make those arrangements on their own, can do that as well. And then the last thing I will mention, I just had something come to mind and now it has gone right out.
That's okay. Okay. Well, if you think about it, you can bring it up. Anybody want to ask her any questions before I move on? And then you may want to hear what we're going to talk about in just a second. We're going to give a report back on some other programs that are going on around the country. But anybody have any questions for Sarika? Is Sarika Mendu again from the mayor's office?
I did remember. So we have actually also tracked by census tracts. So within our districts in the city of Detroit, which districts have the highest populations of seniors, and we're tracking our doses administered by those tracks. So our census team has sort of been redeployed to do outreach, so that not only are we putting up our weekend clinics in areas where we suspect there are a high number of seniors that haven't been yet vaccinated, but they're also going to be starting door-to-door outreach, similar to what they did for the census here just earlier this year.
Okay, good. Hey, I just want to know, did you talk to the mayor yet about bringing me on for the Chamber of Commerce for marketing in the city of Detroit, right? Especially after
top
hours.
of his list.
Yeah, it was great. We had a good conversation about all the cool stuff in Detroit, particularly after 2 or 3 o'clock in the morning, right? So, which is great. All right, well, thanks, Rika, and you're welcome to stay on. So that's a good pivot for me to go over to Mike Kaufman. The CDC held a conference on vaccine. Mike represented us, and Mike, you want to give us any take homes that you thought were important that we learned about?
Yeah, happy to, Paul. Real quick, though, I just wanted to add, as follow-up to the last conversation, Rob Dunny uploaded some really great overviews of their MassVac site in Detroit to our Theater 3 SharePoint site. So if you haven't checked that out, please do, because there's some really helpful information there that we were even able to use when putting together our own MassVac site here in Indy, which I'll share more with you on that later. The CDC's National Vaccine Forum happened February 22nd to the 24th. I was able to participate thanks to some connections that Paul made for me with Dr. Visser and the CDC. On their third day, it was building bridges between public health and healthcare systems to ensure equitable vaccination. I was so thrilled. The overwhelming theme of the day was fostering relationships between public safety, public health, and healthcare. What do we know that as? The EMS, right? More specifically, community paramedicine. And so it was a really great opportunity to highlight how well we can be integrated, what we do, what we've always done, into public health. And I think the big take-home message from it was that public health will never look the same after COVID, and EMS will have a solid footprint within that. So thanks, Paul. It was a great conference, really well attended, and I appreciated the opportunity to be part of it.
Okay, well, then that's great. I'm glad you were there to represent us. They were really impressed with the work you've been doing there, and mostly your enthusiasm, which we want to kind of bottle, but apparently we won't be able to get it all out to the public quite yet. Okay, so we'll see how it goes. Paul. No, you're very welcome. All right, so with that, I'm trying to think if there was anybody else want to talk at all about the vaccine programs. We are going to have, I guess tomorrow's the ketamine, so the vaccine issue is going to be going on with the EMS World thing on Thursday, and you're participating in that as well. And then we're going to have some good Q&A, so I'm glad you're going to be there for that. All right, let me do this. Rob Holman, because I hadn't talked to you for a while, you've been doing some special stuff also in the vaccine rollout in your community, especially on the other side of the river. So can you tell us a little bit about that and what's worked for you?
So we're also engaged with the faith communities, and that's really helping. We're getting a lot of the faith communities in the local neighborhoods to get very involved publicly, have their vaccines recorded and reach out to their members. And we're having vaccine sites at the churches or in the parking lots. So that's really helping as well. We've actually corrected our wealthy, educated ward versus our underserved, poor ward. There was when we first rolled out, the proportion of over 65 between those, there was the wealthy ward had 26-fold higher vaccine rates, and now that's just about 2 to 1. And we're really working on making equity a big piece of our vaccine rollout.
Yeah. Okay, good. So I'm glad you're on, because we're going to get into some interesting discussion about vaccines and immunizations and mask wearing and all that. So I'm glad you're here. Can you stay on for a while?
Sure. Yes.
Oh, fantastic then. Okay, good. Hey, listen, now that we're, January 6th went on, and then did you guys think, I mean, a lot of these people were visiting from out of town, but any a bump in COVID rates related to the January 6th events that in retrospect?
Yes, there was a bump locally post the 6th. I think maybe you saw this in national media that 200 members of the visiting 25,000 National Guard came down with COVID or were diagnosed with COVID in ensuing 7 days. So
Oh,
a
bummer.
lot of exposure. It was one of those big events where the criminals took their masks off instead of putting them on.
Okay, good one. I like it. All right. Well, thank you for the report. I'm glad you're on. So let's see. Hey, listen, before I go on to stuff, I will jump over to ketamine a little bit, but I do want to go over and welcome to the show. Emily Nichols hasn't been on for a while. Emily's our medical director in New Orleans, works with Meg Marino. Fortunately, Emily, I'm going to tell you, Meg's been great, and she's been, really been fantastic. And so anyways, I know you have your regular meeting usually with Mayor and other people at this time. So what happened today?
Hi, thank you, Paul. I did a lot of reorganizing of my schedule over the last month, specifically because I was missing this collaborative opportunity with each of you. And I agree that Meg is priceless and and definitely helps me to keep going. So yeah, I'm excited to be here. I'm multitasking even today because our new regional guidelines are coming out this week. And so I do plan to try and be available more often. So yeah, just thanks for having me, Paul.
Yeah. I don't know if you heard, but I was actually in your jurisdiction back in December and no disasters happened. So you guys you dodged the bullet. Okay. So usually when I come to a city, there's something happens. So it's interesting.
Yeah. Well,
all right.
thanks.
Yeah, go ahead. Yeah, but I'll come see you again soon. So I'd love to hang out and show me around your situation. All right. Since we were talking about tomorrow, we're going to do a thing on ketamine. Well, first of all, Mick, are you free now over in Dublin? Are you off the phone?
Yes, sorry, Paul.
Yeah, good. No problem. I just want to make sure I don't leave you out before I forget. Okay, so anything new to report? Are you guys making any progress with getting some vaccines out there?
The vaccine is slow because we're importing from other countries and the supply has been quite restricted. One modicum of success, we had no new admissions to ICU yesterday for the first time in 70 days, which has been fantastic. So the numbers have been coming down slowly, and obviously you take 5 out, you bring 5 in, but yesterday was the first day in 70 that no new patient. Yesterday or this morning was the first time the COVID cases have dropped below 500 in hospitals as well. So that's a modicum of success. However, the public are now starting to rebel, and there were some protests organized where there was some very large gatherings and people firing fireworks at the police. And it's resulted now in 50 people being arrested and some prosecutions and hundreds of people gatherings with no masks. So we're expecting the cases to start flying up again, unfortunately.
Okay, it's unfortunate. So yeah, what can I say? Just you guys are in a tough spot. I've been following with some of my other friends over there, and it's yeah, it sounds like well, anyways, we're with you, and what can I say? All right, so let's move on to I'm just trying to write some notes to myself about stuff that I want to cover today. So let's do this because we are going to do the ketamine panel tomorrow. I do want to start off maybe with Brett Myers because he's really been taking a leadership role over the past year, which we really appreciate on doing it. And in fact, you have a paper that's accepted for publication on the subject, if I remember correctly. I may be wrong, but Brent, go ahead and take it away. And for those of you who don't know, Brent, who's our Chief Medical Officer and lead down at ESO, and also a past president of NEMSP. If you don't know him, then you shouldn't even be on this call.
Well,
go ahead, Brett.
Yeah, thanks, Paul. And then I would say if you've been to the post office, maybe you would know me, but nobody's been to the post office lately. I don't imagine.
Yeah.
So there's just a couple of things in the way of overview that I think are important. The first is ketamine is utilized mostly for pain and trauma, right? Not for sedation when you look across the country. Right. So I think that's the one important piece to start with as we reflect on it. The other is there's this notion that it is incredibly safe, and it is relatively incredibly safe. That being said, the rare complications that do occur generally can be detected with early and tidal CO2 monitoring. And so while it's recognized for the sedation purposes, often you can't have a pre-end-tidal CO2. Certainly once you have adequate sedation, one of the first steps we would recommend based on what we've seen is add that end-tidal CO2 so that you can pick up on hypoventilation before it becomes hypoxia. And so we see that in a significant number, there is some hypoventilation, a smaller number, there's hypoxia. But the last thing to say is relative risk versus absolute risk, right? So when you look at relative risk, ketamine is going to be a little more risky, perhaps, than a benzodiazepine or an antipsychotic. When you look at absolute risk, the risk of a bad outcome is less than 0.5%, regardless of which one of these you choose. So we have to, I think, caution ourselves when we see comparisons between choices for sedation versus the absolute risk of any complication whatsoever. And so I think those are just kind of an important overview. So I think ketamine has a role. I think benzos have a role. I think antipsychotics have a role. And we just need to be appropriate in our choice and appropriate in our monitoring post sedation. So that would be the kind of nickel take home.
Yeah, and those antipsychotics have worked really well for me, so I can say so. Hey,
well, the depot is helpful, right? The once a month is helpful, so that's
right, exactly, along with the ankle bracelet. Hey, so but tell me a little bit about that. You do have a publication coming out. Is it? Am I right, or is it premature to talk about it?
We do have one that has been accepted and is in the proofs stage, I guess it would be. So what we understand is that we will have a proof next week. So as soon as we have proofs and those are returned back, we can, I think, turn it loose on the public and to the FDA for that matter. Yeah.
Real quickly though, can you tell us what it's about, or just the nutshell? Yeah,
sure. So the gist of it is we looked at every administration of ketamine as opposed to administrations for a particular indication for the calendar year 2019. And that's where we kind of learned that pain and trauma is the #1 indication, but there's still a significant number that receive it for procedural sedation, for refractory or status epilepticus, refractory seizure, and then obviously for behavioral sedation as well. We looked at all deaths, and if you take every person that received ketamine in the pre-hospital environment, about 6% do not survive, which would be an alarming number if not put into context. When we then reviewed all of those deaths, we could exclude all but a very small, less than 1% of them, of ketamine contributing. For example, gunshot wound to the chest where you use ketamine as an RSI facilitating agent. Well, clearly the ketamine's not responsible. So most of the cases could be excluded in that way. So when you put that all together, 99.7% of patients that receive ketamine either survived or died from something completely unrelated to ketamine. So that's kind of the bullet take home.
The thing is,
we've got many co-authors on the call, so I encourage them to jump in and correct me when I go wrong.
And I suspect that some of that's indication bias too, because we use it for the roughest cases. And so I would say, all right. Well, that brings me up to then, Remley, you want to say anything about it? You're one of the co-authors, if I remember correctly. Remley Crow?
Yeah, no, thank you. I think that was a really good summary, and just to keep it in context with what's an appropriate control group that we should be looking at, and to understand that these patients are, just like you said, very, very sick.
Yeah. Okay, good. So Sandy, Nick Simpson, anything before I go on to Sandy Schneider to talk about the FDA comments? Nick, anything percolating up recently in Minneapolis since a lot of this first percolated up there? Okay.
Nothing specific to ketamine lately. We are getting ready for the Derek Chauvin trial to start this coming Monday.
Okay.
Jury selection is supposed to be on the 8th, and then the 28th we start deliberations, we expect. So there are a lot of Jersey barriers and razor wire up around the city, and buildings boarded up again. But we'll see.
Well, at least the temperature is cold there, so
supposed to be in the 50s next week. So we'll see.
I know, isn't that amazing? It's pretty cool. Good for you. Pretty cool. Okay, it's pretty warm. Sorry about that. All right. Well, let's move on down. Sandy, you just want to quickly mention the issue about the FDA report that you're doing, since we're on ketamine. Dr. Schneider, did we lose you?
She looked like she jumped on a phone call, Paul.
Okay, yeah. Okay, that makes sense. She usually has to get off right about now, so that's fine. Okay, good. So let's move on to some other issues. One of the things that came up that the CDC was going to ask us about was this thing about how often people are wearing masks, because they're getting reports elsewhere that people are using them for a whole week, like N95s. So I thought we had pretty good supplies and we were able to get them in EMS. So we put out a quick survey last night that not all of you respond to, but most of you did. I was very impressed. And I'm going to pull it up right now and have some. Oh, you know what I should do is I'll just pull it up with you guys here. I'll do we're going to be looking at the same time, the results. Okay. And so let's see if I can do the screen sharing thingy here. Screen share. Okay. And then I'll do this. Okay. You're seeing my stuff, right? Okay. So let's go to the Google Drive that tells me the answer. So we're going to be looking at this all at the same time. So that's it. Can everybody hear me okay and see the screen as it's rolling in here? Okay, so this is just, this is just the hard sheet. Let me see if I can get out of this here. I didn't want the, I thought that this thing was that's the document. Okay, got it. Let me see if I can go back a little further. I might be able to find the answer to all this. Here we go. I think it's here, but I'm not sure. There's a Survey Monkey. Okay. This usually will give me a summary. All right. Eagle survey on ongoing respiratory use. I assume they're talking about like N95s, et cetera, or whatever it may be. 27 people answered here, it looks like. Okay. We'll skip through all this. Just kind of seeing who answered here. All right. And then I'd like to have some of you maybe give me some comments as specific comments regarding this. Okay, so it looks like we have all these. Okay, I got to skip through all the places that participated. It looks like we got a lot of participants. Okay, so for your EMS crews and your work as an emergency physician, and I haven't seen this, by the way, so I'm coming in cold with all of you. In general, how long do you usually use one N95 respirator before disposing? So it looks like, I'm trying to see if I can see the scale here. Oh, 0% to 10%. Okay, so 6-7%. Oh, here it is. You can put the thing here. So 8%, two of the places said that they use it for one patient. It looks like the clear majority, which is up close to 60%, use it for one day. And then if you add it in 2 to 3 days, you add another 11%. So it sounds like you're, I guess, 2/3 to 3/4 of everybody uses it up within a day or 3. But it's interesting because there are some people around here, at least 3 organizations, 12% or so are using it for more than 6 days. Okay, so we may then ask people who answered in that thing, why is it going out? Oh, here's the breakdown right here as I was going through that for you. So there it is. But it looks like the clear majority are for one day. Okay, then our EMS personnel are working in EMS or ED currently using surgical or medical face masks. I assume that's like N95s and just the simple surgical masks. So I guess they're saying yes, and most are saying no. So is that what that question was? How did you guys understand that question? Was it talking about using like a simple surgical mask? Those who answered this, is that what you were thinking? Anybody?
Paul, it's Crawford.
Say again?
It's Crawford.
Yes, Crawford, go ahead.
I was actually a little bit confused about that because in the emergency department, we wear N95s and surgical masks for those patients. So I guess I should have put that in the comments or something like that.
Okay, got it. I'm not sure if that's a value for me. I wanted to know about the N95 specifically anyway. So, okay, please, any discussion points. So I guess I could go through these. We use the durable elastomeric, the question is quite unclear. Okay, yeah, we got it there. So everybody agrees with us so far on that. Mass supply seems good right now. And that's up in Portland, right, John? You said we do not use N95s, you use P100s in your population. Okay. Anyway, anybody want to make any comments about this or give me a reason for 7 days? Anybody have an answer for that? And the answer is no.
Are they cleaning them? Are they sterilizing them? Because we were doing that initially in our hospital.
Okay. Is it because you just can't, the people who answered that, if you're because you just couldn't get them, You know, are you having a supply? Anybody have? Well, let me ask a more generic question. Is anybody having a supply issue right now with N95s?
Yeah, Paul, Jeff Goodlow, Oklahoma City, Tulsa. We're still having some supply issues in EMS. I think
Okay.
that this poll is very helpful. It will allow us some leverage to increase the efforts to find them. Given I'm truly surprised that so many places are only using them one day. That's really surprising to me.
Yeah, and it looks like it's clear majority, you know, that kind of thing. So if you average out the 2 to 3 days, it's almost like clearly 3/4 are only a day or two. So that's really interesting. Okay. John Kramer, you've been tracking that. Anything you could add to it in terms of what you know? Are we seeing that in certain cities, areas of the country, or is it still a supply chain thing, or just people just don't know where to connect in? I don't know, John, you're back and forth between calls, so I don't know if you could hear me or heard my question.
Oh, I'm sorry. I just walked in as you said John Kramer, so I don't know what the question is.
Yeah. So John, we're talking about the N95 mask. It turns out that some people are using them as late as a week. You know, they're using them. They don't get rid of them for 7 days. In some cases, the majority are using them just for 1 day alone. And then, so we're trying to. Some people are saying they do have some supply chain issues, and so I'm trying to ascertain, because this was a big interest to you. What have you learned? Is it in certain areas of the country? Is it people just don't know where to call and they are available? What's your read on all that?
That's an interesting question that hopefully I'll have a better answer for Friday. We've got a supply chain meeting on Friday to talk specifically about this. It does appear to affect rural areas more commonly than urban areas, based on the anecdotal information that we're getting right now.
Okay, got it. And then just for your information, we just see if I can pull it up again. I just had it here a second ago. Nope, I lost it. I guess I'm gonna have to just go back to it. I'll just pull it up again. Oh, maybe it's here. There it is. We actually did, just so you know, we did a survey of people that were using them, and we only got 25, 26, 27 responses. As you break it down, this is 2 of the systems reporting out whatever it was. Oh, it looks like 25. Okay, so had used it for 1 patient only. Most are using it for a whole day. Close, more than half of them are, and then maybe 2 to 3 days, a few more. And then we're still over here about 3 systems, or 12%, if you want to put it that way. We're have been using them for more than 6 days. And Jeff Goodlow was just telling us that he's still having some issues, even in Tulsa, Oklahoma City, getting him these data were going to be very helpful to him, trying to convince people we should do it. So we'll try to, we're going to get more data back on this, because we just put it out late last night, and I'll try to send that along to you this week, so you'll have that in your back pocket. Okay.
Yeah, I saw that online. Thank you.
Okay, good. All right, good. All right, so let's see where we want to go next. I just wanted to make sure everybody got to hear that, et cetera. Anybody have any more comment on that particular issue?
Hey, Paul, this is Dustin in Cincinnati.
Yes.
I was one of the ones that responded, and just to clarify, I think I did in the comments, but it's a very different situation for my EMS groups versus me and my ED colleagues, and the questions seem to blur the two a bit. So, like Cincinnati Fire uses the elastomeric, so they're cleaning it. Most of our fire departments are using N95s, and they're using them for a day at most. Whereas in the ED, I typically, for a 12-hour shift, will wear an N95 the entire 12 hours. So while we have a pretty good supply in our hospital of N95s, some of them are better than others, and some of them are really uncomfortable. So if I try and wear an 1860 for the entire shift, I have no skin left on my nose. So I'll get a hold of some of the 1870s or a couple of the others that are out there that are really comfortable, and I'll just take really good care of them. Always wear a cover mask, always wear a shield, and I will pull that thing out for a week or so at a time sometimes.
Yeah, right. Okay, got it. All right, yeah, I totally understand what you're saying about the nose piece for sure. My nose is just totally butchered. So I got it. Maybe I have to work on getting a better design for the future, which will be kind of cool. All right. Any other comments about this before I move on to the next subject? I guess that's it for that. So let's start talking vaccine a little bit in terms of the J&J, Pfizer, Moderna, and hopefully we'll have Rob pitch in, John Jew, et cetera. And the classic question that all the EMS and firefighters, I've been in 3 or 4 different fire stations, well, maybe 6 or 7, because I was in 3 or 4 different services over the last couple of days here in Palm Beach County. And one of the questions that comes up is that why is there one only 65% versus the Moderna and Pfizer? And I talked a little bit about the apples and oranges thing, that the populations they were testing might be a little different, maybe even younger, and was earlier on disease. We may have more variants now, and I threw out all that kind of stuff. But I just wanted to see if we had an opinion about the pros and cons and advantages of J&J. And I hope this is a little bit off the record, because we're just giving an opinion. And I think the most important thing is to get as many people vaccinated as soon as possible, and that we should, maybe encourage people that if it's the only thing available, get it, that kind of thing. That's the bottom line here. But so Rob, or let's start with Rob, and I'll go to John Jew. Any thoughts about that, or what do you know so far? By the way, these are 2 infectious disease guys, Rob Holman from Washington, D.C., and John Jew from Portland. Rob, are you still there? Okay, maybe not. Then let's jump over and get on with John Jew. Okay, John, any thoughts about that?
Yeah, Paul, about 2 or 3 thoughts on that. First of all, the J&J vaccine is much easier to operationally handle, as everybody knows. It doesn't require freezing. It stores very well. It's one shot, and you don't. More importantly, you don't have to have the patient wait 15 to 30 minutes here as well. The other advantage that J&J has is that it's the probably the most recent vaccine against the variants. So we have some data against the variants, including the B.1.1.7 and even the South African B.1.351 here as well. The third item is that, remember, J&J is only one shot. No one really knows what could happen if you got 2 shots. The efficacy could go up, but that's just hypothetical right now.
Right.
Exactly. But I think the vehicle that J&J and AstraZeneca is well proven. It's a adenovirus, inactivated adenovirus. The AstraZeneca is the chimpanzee adenovirus, and the J&J is an adenovirus, I think type 26 or so as well. But the J&J gives that option. Yep.
Yeah, so let me throw this at you, and you don't have to answer this. You could say, I'd like to plead the fifth or whatever, right? But if you had a family member who you really want, daughter, son, uncle, whatever, that you really wanted to get the thing, and they said the only thing they had available was the J&J, that kind of, and they say, hey, I want to get the Pfizer because it's 95% versus 65% effective in stopping it. What would your advice be? Get it?
Well, if it's the only thing, get it. Absolutely. Yeah. So J&J vaccine is a lot better than getting COVID as well. Yeah, so it's sort of right. like a easy question to answer.
Yep.
Some Europeans have actually tried to do the following, that the higher risk, because the higher efficacy, albeit, would be the mRNA vaccine. So if you had your magic wand, you had the J&J go to the younger individuals, and the higher risk individuals go to the
right.
Moderna and Pfizer.
So you just opened up exactly what I was going to maybe pivot to, which was that one of the reasons why the influenza vaccine is usually 65% effective, meaning in stopping the disease, but it also mitigates you from getting real sick. And I think this is very analogous. And again, the people who are more apt to get sick are going to be the older people who are not developing the antibodies as well, or it doesn't have as good of an immune response. So it's the same thing. So it may be also consideration, as we brought up last week, that maybe with the older people we'll have a higher, higher concentration of dosing like we do for influenza, or maybe some booster shots or something like that eventually for them. So that may, and I think your idea about targeting some of the younger people, I bet you it'll work really well for them. So that's a really great point. John, just in case people don't know, can you tell them about, is there a difference between the vaccine you get if you're getting your routine influenza shot, if you're 65 and older or under?
Yeah, you get the this is personal, the hyperimmune, I say the flu shot on steroids. So you get the higher concentration of flu shot on steroids as well.
Yeah, yeah, I didn't know that until I went there last year, and I got thing, and they said, "Yep, oh, you're over 65." I go, "Yeah," so we're going to give you this one, and I go, "What do you mean this one?" You know, and so it's more of a concentrated dose. It's kind of interesting. So that may be something we think about here as we learn more about how to deal with coronaviruses. So we'll see how that goes. So, John, I'm going to put you a little bit on the spot once more. I threw something at John this morning that just came out in JAMA. It was a letter. So it was kind of buried somewhere, but still kind of interesting discussion about a study they've done recently with vaccinations and neutralizing antibodies. And maybe you can tell us a little bit about the patient population they looked at and the results they had, and set it up for us, John. And sorry to put you on the spot, but you're the guy, okay? So.
sorry, but it was like a curveball here. This was an interesting letter. Basically, they took from, I think, Maryland, they actually took a cohort of COVID naive patients, in other words, healthcare workers who had never had COVID, and they also took another cohort of healthcare workers that had asymptomatic COVID and symptomatic COVID, and then they looked at the antibody production after the Moderna Pfizer shot, I believe. It is Pfizer.
Yeah,
I believe it's Pfizer. And what happened was the following. There's actually three things. Number one, that the timing of the appearance of the antibody was approximately 14 days. So that actually correlates with our data to completely agree with the fact that you're not really protected until you have the antibodies. The second very interesting thing was that this is one of the first studies that actually documents the fact that asymptomatic and probably symptomatic healthcare workers who had COVID mount a almost equal response as far as neutralizing antibody. They also performed a regular antibody and a neutralizing antibody, and they had significant titers. So that's the following. So number one, if you've never had the COVID-19, you don't get any protection until day 14 and on. Number two, that if you had experience of either vaccination or prior native disease, you get a very hyperimmune response to the first vaccine as well, protection.
Yeah, so it's kind of going along with stuff that would be intuitive, and we're finally figuring out, and it's good. And this is great because they actually did serological studies versus like the presentation we did last year, which was our kind of our backyard high school science experiment that was really impressive, actually. So it's kind of cool. We actually have, by the way, that's a good way to actually segue into the fact that we have some new data. Peter, do you want me to put up a slideshow? Because I've updated it for what happened with day 28, or I mean, sorry, day 42. Is that okay? Or are you available to talk about it, Peter Antebi?
Yeah, but I don't have it in a slideshow, but thanks, Paul, for doing that.
I got it. I'll put it up for you. Okay. So if you don't mind. Okay. So I got it ready to go for you, as a matter of fact. So, all right. So first of all, go ahead. Just to remind people that we looked at people who are being vaccinated, and we looked at them in a nursing home, and this included people 20 to 90 years of age. And remember, those are because they were staffers there. And this
how are you?
We get them reoriented.
We need to go on headphones here.
I'm sorry, who's live? Someone's talking. So anyways, what was fantastic was that we looked at people who had, weak responses versus strong responses. And here's somebody named PA on day 22, just before the second shot, was light, and then look at about 7 days later, really lit up really well there. So, so anyways, first of all, Peter, what happened here? This is day 0. Almost, there were some people that had some IG, so maybe they were exposed to the bug at one time, but the majority of people, 94%, had no band whatsoever. So essentially, most of the people didn't have any kind of antibodies floating around, correct?
That's correct, Paul. Yep.
Yeah, and then going along with the day 14 thing, this is why I brought it up with that John just talked about there. You could see that on day 14, for participants under 70, there was some response in antibodies, whether it was IgG, IgM, or light or strong. Whereas for the people who are 70 and older, a smaller percentage had it, and the majority had no band whatsoever here, that in gray there, okay? So that's just sort of the quick setup. And that, of course, goes along with this thing that we talked about, that on day 14, and here it is in a blow up here, I'll blow it up a little bit. you can see that's where the breakoff happens, and the placebo group versus the people getting the vaccine. So that was pretty interesting. And then we showed that originally that on day 21, all these people under 50 were making antibodies, and then it stair-step down, et cetera. So let me jump ahead. As we later showed that they got really profound responses after the second shot here. And even in the group that was the 91 to 100 on day 28, but we still were missing some people out here in the 80 to 90 range. So Peter, tell them a little bit about what happened now on day 42, okay?
Right, so here on the screen, you're seeing that this is the strong band on day 42 is in everyone except a few people there. Again, in the 80s and 90s, you see it stair-step downward once again. So here we are 3 weeks after dose number 2, and you can see that there is not really the full antibody response that we would see in the younger population. And then
the good thing I'd say is that the cool though is up to 80, you're in good shape, right? And it's still in the group of 14, there's maybe 2 people in the 80 to a 90 group that weren't doing so well, relatively speaking, right?
And Paul, that's a good point. If you want to just back up one, because in this subset there, go forward one.
This one, yeah. Okay.
Right. In the 81, there's an 89-year-old in this group who's on 2 immune suppressants, including a steroid. So that person just wasn't making antibodies the entire time. So if you take that person out, then you have almost you're almost at the full scale here. So that's a good sign.
And that's why I put this in as a better late than never that day, because it took up the 42 days. They weren't doing it at 7 days after the second shot, but by 3 weeks after the second dose, they're doing much better. I did a quick comparison of day 28, which is 7 days after the first shot, versus 21 days. And you can see we are definitely gaining ground there, although not perfect, but there's some reasons, as you said, because they're on some immunosuppressants into the situation. But overall, I thought this was pretty cool after 3 weeks. Right?
And then the last thing we did, we looked at, okay, we're not there yet. I was going to talk about the neutralizing antibody.
Was there any antibody, light or strong, on day 42? And you can see it's really coming close to 100% across the board there. So there was something there, right? What do you want to look at next, Pete?
The neutralizing antibody, if you have that.
Okay.
Oh, okay. There you go.
Sure. So here's the day 28 one, remember? And it was really pretty low over here. But what I'm going to do here is now jump ahead, and this is day 28. That's 7 days after the second shot versus 3 weeks after the second dose. And there is a difference here in terms of that.
Yeah, so it looks like there's a slight increase in the overall positivity rate. What we're calling positive is anyone over 30%. So this is just a yes or no. It's not an actual value, but on the upcoming slide, you'll see that we have a quantitative number, and you can see here.
Paul, first of all, this is day 7 after the second shot, right? And look what happens now. That when you move to, I got to get rid of this thing on my screen here. Sorry about that. There we go. Okay. And then look what happens now when you put in day 42, which is 21 days after that. And you can see how this is going uphill here. Almost everybody's got the average neutralizing antibody percentage is pretty high. And the neutralizing is pretty high, but it's still up there. And this is still on the average in a positive range here, even though it's better than it was before. But Peter, give the caveats about all this, okay?
Well, remember on day 42, there's a big caveat, and that this test that we're using is not FDA EUA at this point in time. So it is an analyzer. It is a test that we're looking at to try and validate the test. Remember that any neutralizing antibody, and there are tests coming on the market now that are not kind of quantitative, but are maybe semi-quantitative, and it'll be interesting to see what the FDA approves or not. But in order to have a good neutralizing antibody test, you should probably have a number associated with it, and this is kind of why that is. The CEO of Pfizer said that at 6 months, they're finding the neutralizing antibody levels in their participants were, in his words, very robust. I just think that the older people are just taking their time to get there. But clearly, when the average value of a 91 to 100 is 35%, and they're calling 30% the cutoff for positivity, I'd still be interested to see what happens over time in that population.
Yeah. So
yeah.
That's good. And it looks like up to 70 you're really got relative protection. This is down because of the person that's on the steroids, I think. Yeah,
that's correct. That's correct. Yep.
So this is not perfect, etc. But anyways, it's just the conclusions are that it looks like the younger people are cranking it out by day 14, and they're almost doing a great job by day 21. And after the second one, obviously, I think they're going to have a really good response under those circumstances. And then it could lead to a question that maybe if we go overseas or elsewhere or wherever, who knows, if we really had to prioritize a second dose, that maybe we could hold off on them. But I'm still supporting that we get a second dose in everybody. But the second dose caused a more dramatic antibody response for sure in those people who are getting a strong antibody response. And it may take up to not just 1 week, but maybe, because at 1 week we saw a great response, but at 3 weeks for the real older people, it may finally kick in. Still, not all people have a high percentage of a detectable neutralizing, assuming that this, this technique is accurate or relevant or whatever. But it implies the issue that maybe the elderly need a more concentrated dose like influenza vaccines or possibly a third booster. But it's all, as the CDC said last week, it's all hypothesis generating. They thought this was pretty cool. Thanks for the backyard experiment, Peter, because it's really kind of neat what you did here. So thank you very much. Okay. So.
Well, thank you.
Anybody have any questions about that?
Yeah, just a quick comment, Paul, if I can.
Yes.
So I would say that a couple things. First, we still don't know what the correlates of immunity are. Meaning, we don't know what antibody levels give you protection, whether it's T cells give you protection. But put that aside, for the folks that have been pushing the one shot, get everybody some protection standpoint, I think this data really shows that might not be the right call for the older population. Maybe for the younger, but the older population, you see, you get some difficulty getting those antibodies. So I think that's an important piece of data to put into the mix.
Yeah. Okay, good. Fantastic then. I really appreciate it. All right. Any other comments, Rob or John in particular?
Yeah, Paul, I agree with Ken completely. Peter is fascinating data here as well. So I think the what's really not known is you need to look at the rise of the antibody in relation to the pathogen, which in this case is SARS-CoV-2. So in other words, the SARS-CoV-2 actually inhibits interferon. And if you inhibit interferon, it inhibits the B cell and Th1 response. So if you're younger, that's really important. If the younger individuals actually have a significant Th1 response, which makes the antibody. The older individuals have a sort of their Th1 cells went to sleep, so they have to be woken up regarding that, and that may have a lot to do with the virulence in the older age group here as well. So I agree completely that the one shot is not universal, and I'm actually in Ken's camp where if you had to have one shot, you should give 2 shots to the older individuals.
John, any thought about a third shot for the elderly?
Yeah, I think the third shot for the elderly might be even. It depends on what your elderly is, Terry. So it depends on what it is.
Elderly is anything
I'm 69. I'm elderly.
Yeah. I do expect. My personal belief that, as everybody knows, Pfizer and Moderna have a booster shot in phase 3 right now, as of last week. So I expect the booster shot in 4 to 6 months.
So it's kind of interesting. Hey, just to answer your question though, Terry Valenzuela from Tucson, is that I was actually in Phoenix not too long ago when I was out with the Rolling Stones, and I met one of the drum technician's mother, and she was 87 and she was just spry, and we're talking, and she defined elderly as anybody over 15 years older than you. So when you were 20, you talked about don't trust anybody over 35. When you were 35, you said, oh, they get their AARP card when they're 50. Obviously, the 50-year-olds are talking about 65 olds getting Medicare, et cetera. And then you're talking about octogenarians when they're ready. But she said when you get to 87, it goes backwards. So just so you know, right?
Great.
Yeah.
So they're elderlier people 15 younger than you then. All right.
There,
All right,
there's
go ahead,
one comment for Mick Malloy. The UK just this morning released their information on the effectiveness of the Pfizer and the AstraZeneca vaccine against the B117. It is effective against the B117. It's the first real world data that's out there.
Outstanding.
It's
Good
on
news.
it's on the UK data set side.
All right, very, very good. Okay. Let's pick up, just wanted to do some random runarounds here. I don't know if there was any else specific things that we wanted to go over, but we haven't talked to Dave Slattery for a while from Las Vegas. So Dave, if you're on, if you can come on and tell us how things are in your neck of the woods, especially with people trying to get the casinos all open up. Has that caused a problem for you? And are you doing okay out there? David?
Yeah, good morning, good afternoon, everyone. Good evening to some of you. Able to hear me okay?
Yeah, absolutely, Dave. You look great and you're doing good. Okay.
Yeah.
What happened? You look good.
Right. Right. 8 months after COVID. Yeah, that's right. So Vegas is doing well. We're opening it up kind of a gradual fashion. The casinos have been operational. I just got off the exercise bike, so I'm panting a little bit. Casinos have been opened up and in a gradual phased fashion, and they're doing well. All employees are getting tested routinely, as well as very strict protocols for both mask wearing and physical distancing that really has transformed all of our cultures. And so just this past week, the governor's released a little bit more, allowed us to start having some shows again. Did the Las Vegas Golden Knights NHL game last night, the first time in the T-Mobile Arena that we allowed actual fans, which is fantastic. Again, in about a 15 to 20% capacity and physical distancing for them. So otherwise, we're doing well. Our fire department has been vaccinating initially our fire department personnel, and then expanded to the city and several pods, just like most of your communities have been doing. We still don't have as much of engagement with our fire department personnel that we would like in terms of the number and percentage of people that are actually getting vaccinated. But so I'd love to hear your strategies for increasing that engagement. But that's kind of where we're at in Las Vegas.
Okay, good. Well, I mean, that's a nice thing. Maybe that's a good segue over to Ken Shepke, who's been taking kind of a lead across the state in Florida on that particular thing, David, and several others there. Mike Hoffman, who had to get off, and a few other people are doing some good jobs there. People like David Miramontes, I can go on and on. There's a lot of people doing a great job here. But Ken, why don't you give us an update from your point of view? If you're still there.
The state's progressing pretty. Yeah, I'm still here. The state's progressing pretty well in our vaccination. We've gotten almost 1/4 of our population has been vaccinated as a whole, and about it's over 50% of those over the age of 65. In fact, the governor just opened it up to a couple other populations. We're going to be vaccinating all of our educators from kindergarten to age 12 who are over the age of 50. We'll open it up to the police, sworn police officers. Also, though, age cutoff for them, age over 50. And we have expanded, the governor had initially limited those who are under 65 but were considered medically vulnerable had to be done at the hospitals, but now he's expanded that you can now get that with a physician's prescription. So now we've really expanded to anyone that a physician feels is medically vulnerable to COVID can write a prescription to get that person to be in the line for a vaccine. So all in all, doing pretty well. We've seen
Ken, I want to interrupt you for a second because you may not have heard it, but what Dave was asking about was the issue of the firefighter and the EMS hesitancy issues on the vaccine and how the fronts that that's what I was trying to get you to pull into is talk about what fronts.
I apologize. Yeah, I'm driving and the internet cut out, so I had to call in again. So I
I figured that. That's why I wanted to interrupt you. So go ahead. Yeah.
Absolutely. We've been working on that as well. And it really seems like there's almost cliques, almost by station and by shift, where there are literally shifts where just about everybody has been vaccinated and stationed just about everybody, and others where almost none have. So I think there's been a number of things that we've been using. We've been doing a bunch of myth busting lectures, videos, webinars, and the latest things we've been doing, and Paul, I think you helped us out with this as well, is actually visiting stations and doing one-on-one conversations with these folks. And it does work. I think what we found what works the best is when peers have been vaccinated and share their experiences, and when the medical director, a trusted medical director, goes in, actually speaks to these folks. I think both of those two things help drastically. And one of the arguments I keep telling folks, and I think it sits well, is we're not getting out of this pandemic until about 80% of the world's population, not just America, but the world's population, has either been infected or vaccinated. So it's really not a choice between vaccine or nothing. It's a choice between vaccine and disease. So you need to look at it from that standpoint and decide which do you think is the safer path for you. So I think all those arguments have been helpful.
We studied this actually a few weeks ago, David, and we actually found that one of the most useful things, the most productive thing was, well, things like Ken Shepke put together a really nice little video that set out, and they used it in Indianapolis across the whole state, and they gave him a lot of credit for it. That's why I brought him up. But one of the things that we found across the board in all cities is that when the medical director did address people, often one-on-one, especially in a group at the table, or went over and had lunch or had dinner, and especially if you didn't go in there trying to convince them, if you went in there just talking about different things that was happening, then they ask you the question, then it really takes off. And that takes a lot of work, but we need it because we got to get them on board. The thing that I'm finding is that there are some fire chiefs that are finding these holdouts that they may actually tell them they can't work. It'll be interesting how that happens, but some places the unions are actually going to be supportive of that to protect their own people and and keep people on the job and all that. So I don't know, Ken, have you heard anything further on that issue across the state?
There's, I'll tell you in the beginning, it's probably not going to be popular among the firefighters and paramedics. In the beginning, this was considered a workers' comp related thing, and it didn't come into your sick time and stuff like that. But I think there's slowly, and I think a bunch of the Eagles have mentioned this also, been a push to say, you know what, we've got this vaccine, it's 95% effective. If you choose not to get it, that's kind of on you, and it's going to be on sick time now. And I'm starting to see leadership start doing that, and other sort of, I don't want to call it peer pressure type thing, where folks have been vaccinated in a station and they want to start taking their masks off. And I know we had this conversation earlier on the Florida call that, if everybody's vaccinated at the station, can you then take your mask off and start having a little bit more of a normal life again? And obviously you cannot do that if there's those among you who have not been vaccinated. And the debate is, well, can you do it if everybody has been vaccinated? So those type of things are starting to occur now, Paul.
Yeah. One of the things I found as I went around to different stations, different places, even in your jurisdiction, Ken, is that that there's always, it's like you said, there's maybe a station, and what happens, one person came back and just fed them a lot of stuff about the death that happened and some doctor from getting it, and you're going, what are you talking about? So I actually talked to Sue Visser about this, and they're tracking all this stuff. And I said, I talked to all the Eagles, and everybody, they're tracking all their people. They care about their people, and they want to see what happened to them. At worst case scenario, most people are just feeling like crap for a day and a half. I kick their butt, particularly if they had COVID before, but then they get over it and they're doing fine. There are people are not dying from this, and we've had it now in millions, tens of millions of people across the country. So part of it is just getting out there and telling them the truth and getting those facts down. So I think you're right about that.
Paul, I got to say, I can't tell you how many times I've heard this, that somebody had a bad outcome and they attributed it to the vaccine. When that's not science, right? That's not cause and effect. And I've had multiple times to explain the difference between coincidence, two things happening at the same time but unrelated, and cause and effect. And I think they get it. When you start talking about how every single day a certain number of people have blood clots, heart attacks, strokes, die, whatever, and now you've got almost 80 million Americans that have been vaccinated with this thing. Have you seen a rise in heart attacks, strokes, blood clots, and whatever? And the answer is no, which means there's no cause and effect. So if someone has a heart attack with the vaccine, that means they probably would have had a heart attack without the vaccine. So it's not a cause and effect. So I think that's an important discussion to have one-on-one. It's a little more difficult to do that on a webinar, but it's useful.
Yeah, and then the sterility thing always comes up. They throw around. I said, what's the mechanism? There is no mechanism for that. It doesn't make sense. It's mRNA, and then but I'm more worried that my daughter who got COVID is could have a long-term effect. That could be one of them. That's the risks are outweighing. Let me switch over to Washington, D.C. Rob, if I remember correctly, you guys did take a stronger action, maybe even on paid leave regarding quarantine if they weren't vaccinated. Is that true? Rob Holman in Washington. Oh, Rob, are you there still? I don't know. Well, anyway, so actually, he wrote it here in the chat. He goes, "We eliminated paid leave for unvaccinated on quarantine in Washington. We're re-sticking with masking." Okay, that's it. Angus, over in Tampa, in Pinellas County, tell us a little bit about your discussions today earlier about masks amongst the medical directors in Florida, because I think you agreed a lot with what Ken was saying, if I remember correctly.
Yeah, sure. So I think there's sort of a couple of different points of view on this. One is that if you allow the masking in the station to get rolled back, if everybody there is vaccinated, then that may be a method to exert some peer pressure to get everybody vaccinated. And that's probably a very valid point, given the communal living situation there. I have heard, and there's some others that also articulated a few other arguments against eliminating the masking. One being we don't have any, for many of us in the way our organizations are set up, we don't have a way of verifying who's been vaccinated and who's not necessarily. So that's one issue. The second issue is, and I think this is one that really resonates with me, is that while we are in this period of time where we're exerting pressure on the virus to mutate, I have concerns as to whether or not we would detect a new mutation that's able to get around our therapeutics in time to prevent that spreading. And similarly, not allowing a continued spread among young people as reservoirs, since we don't have the definitive answer on carriage and asymptomatic transmission.
And then let me jump over. So I mean, I think that's really a good point, and I am still trying to stick to masking personally for those reasons, and particularly in a older population of medics and so on. Chuck, what did you guys do about it in Little Rock? Chuck Mason, what's happening there in terms of paid time off and all that stuff during quarantine if they're not vaccinated?
We have eliminated all the paid time off for quarantine, our exposed medics. We've also gone to the fact that we test everybody for antibodies. If they show up, we won't put them on quarantine anymore either. They go back to work.
Okay, got it. All right, anybody else have any policies like this or they can comment on here? What's happening, for example, say Joel and Chris are on over in San Diego. What are you guys doing out there? Chris, are you there?
Good morning. Sorry, I just got a little distracted by news going around about our, he just apparently had a mass fatality crash out in Central area.
Sorry to hear that. Okay.
Yeah, apparently 27 people in SUV and 15 of them are dead. So.
Oh, geez. Wow. Okay. That is kind of distracting. So, okay, but go ahead then, Chris.
In terms of, so I'm sorry, I believe the topic was vaccination and masking.
Yeah, and then some people are saying they're not going to have paid leave if they have to quarantine because they didn't get vaccinated and all that, etc. So that's
so we haven't gone to taking away the paid leave yet, but it is something that that's certainly been discussed. Right now, our vaccination refusal rate still hovering around 15 to 20%, which means that we're still getting pretty good coverage, but we're also not allowing anyone to do away with masking in this station, even if everyone's vaccinated.
So maybe that peer pressure thing will come up, and then add in the educational things that we've been talking about will make a difference, I hope. John, you asked me about the CME codes today. I totally screwed up. I should have given that to you. But the CME code for today is 12950. So 12950. Usually Jim is on with us. He unfortunately is traveling right now, and Jim usually puts it up for us. So it came in the email earlier as well. So 1295050. Okay. Thanks, Jeff, for putting that up. All right, well, that's really interesting. And by the way, Chris and Joel, I just want you to know that I was asked to do this thing for that. You're going to be the local docs for the Cardiac Arrest Survival Summit, and they put together an Eagle thing, and I threw you guys' name in there just so you know that, okay? So just to give you a heads up on that. Let me, hey, John Kramer, before it gets too late in the hour, and I know you're jumping back and forth between calls, is there anything you want to tell us about? And I presume I'm going to be seeing you tomorrow as well, hopefully on the call. And maybe this afternoon, right? I think. John, are you there? John Kramer? All right, well, if I can, Joelle, are you going to pipe in and say something?
Say something in addition to what Chris already said, or?
Yes. So that's it. I just saw you popped up on the screen, so I just wanted to make sure I wasn't leaving you out. That's all.
Oh, no, he was correct.
Okay,
I don't know why I popped up. I think, that's what I popped up for, is that I was going to say, yes, we are assuming our Cardiac Arrest Survival Summit will be in person in San Diego. So if you have the travel bug, we'd love to see you, as long as it's safe.
You got it. And that's going to be that, I think, first week in December, like the 2nd through the 5th or something like that. But anyways, we have an Eagles, probably going to, like we did last year for them. We're going to have an Eagles, whatever's concurrent session. And I got you and Chris plugged in with that, as well as some of the other West Coasties here that are on the phone with us today. Okay, so it's now about 12:50. Anybody else want to say anything? Garth, we haven't talked to you for a while. You've been busy because of some personal issues, I know. And I just want to make sure you're doing okay. We miss you, buddy. And so how are you doing? Okay.
Oh, well, thanks, Paul. Yeah, it's been tough couple of months for a variety of reasons. But just to add on to a couple of things that were said about strategies for vaccinations within the department. So the Phoenix Fire Chief's kind of doing something inventive. Anybody that is eligible to deploy for FEMA or for wildland firefighting who could traverse borders, she's basically insisting that those people get vaccinated or they can't be part of those details. So that's maybe a strategy you can try. Mandatory quarantining for going overseas and coming back is another strategy that if you're vaccinated, then you don't have to do that. Maybe something that can be tried. About the what's going on in the Arizona area, it seems like we're basically relatively COVID-free, even though we still have the 6th highest fatality rate per 100,000 in Arizona. One of the big things in the lay press was prisoner advocates have been really distressed about the number of cases in not just inmates, but in staff in prisons. And I live next door to one of the county epidemiologists, and we talk about these things. And he says that the Johnson & Johnson and later on the AstraZeneca 1-dose vaccines would be ideal for those populations because those populations are easily lost to follow-up. And I was just wondering if there's any input on that from this august group.
No, it's a great concept. So that's good. Anybody else? I do want to switch over to, yes, go ahead. Yes, who's this?
It's AJ.
Yes, AJ.
Years ago, you guys told me to go over and talk to the folks at EasyIO, and it ended up being a revolutionary discussion. And I just finished my discussions with a colleague of Dr. Antevi, Dr. Paul Lewis.
And before AJ, if you're going to talk about another subject, can you hold off for a second then, if you don't mind? Okay, good. I did want to switch over to David Miramontes. David, you're always such a creative, innovative person. What's happening on your end in terms of helping with vaccine confidence amongst the firefighters and so on? Anything to help David Slattery out with on that? David, are you there, Miramontes? I don't know if you can hear me. Oop, they lost him too. Well, we'll check in with them later, David. I'll try to get him to plug in for you later on. So, okay.
Hey, Paul, I have one other thing on that issue, if that's all right.
Yeah, go ahead.
There's actually a bill in the Florida legislature right now that's making COVID infections presumed to be occupational among first responders unless they meet certain criteria. And if they have been offered a vaccine and decline it, then they're not eligible for that. There's a little
Interesting.
caveat that the language they put in there says an FDA approved vaccine. And
Yeah.
I've heard some argument that an EUA is not a full approval, so I'm not sure how that's going to turn out. But they're
Okay,
trying
got
to
it.
do it from a legislative standpoint as well.
All right, let me, I'm going to try once more for David Miramani's. David?
Yep, I'm on. Can you hear me?
Yeah, I don't know if you heard what I was talking about before. You know, David Slattery's coming on and saying, how can we help with vaccine topics with the firefighters? You're always very, very creative in your area, and you know, you've always done a lot of progressive stuff. So is there anything else you could add to the discussion about that?
No, I think we've done exactly what you're talking about. We did discussions. We're trying to push it. I think there's a lot of peer pressure that's going on. Just right now, actually, it's kind of interesting. We have decreased availability of vaccine for our healthcare workers and firefighters because we've moved on to the community, and we're doing so much with the community now that it's actually difficult to get the stragglers back into the program. So we have to be a little creative and kind of sneak them in through the process, which is kind of interesting.
Well, anyways, I'll let you know, just as on a personal level between you and me.
I saw your son got his vaccine. Perfect.
Yeah, right. Exactly. So thanks a lot for helping out on that. It's great.
Well, just so in all transparency, we have a volunteer program in San Antonio. So if you do 3 shifts of working in the vaccine center, you're eligible to schedule a vaccine, even if you're not in a high-risk tier. It's kind of like the bring to senior type thing, and that's so that we have folks that can volunteer for the vaccine lines.
It was great, and he does have you do have exposure out there, so that's great. And he's going to continue. And you know him; he's always going to continue to volunteer no matter what. So which is great. Right. All right, well, look good. Let's see, John Kramer. Any chance you're back on? And just to sort of see if there's any report from you. Otherwise, I'll talk to you this afternoon. We got a meeting in about an hour together.
Yeah, Paul, nothing real out of the ordinary. I mean, we're continuing to focus primarily on the vaccine issues, hesitancy and things like that. We have spent a little bit of time looking at the ketamine issues in the National EMS database, but nothing definitive to report right now.
Okay, good. All right, good. I just want to make sure I got to you before we ended up here. And then anything either from HHS for any part of your world, any chance, Andy, if you're around?
Hey, Paul. Hey, everybody. ASPR is really doubling down on monoclonal antibodies. I know there's another purchase that just went out, just really pushing that therapy to try and keep people out of intensive care who are at risk and symptomatic. NDMS is also supporting several West Coast sites for sort of the mega clinics, the vaccination clinics, where they're out working, I believe, in California, Arizona, and some other locations, and have been for quite some time. We just passed the 1-year engagement where we've had people continuously in the field supporting COVID. I know I was one of the first groups out February, early March, a year ago for the quarantine mission on the cruise ship when we farmed folks out to the military bases and got to hang out with Dave Miramontes a little bit down there.
Yeah.
Seems like weeks ago, but it was a year. That's about it that I'm tracking on. Got a presentation picked up for the NACCHO Preparedness Conference. I've told you guys I've been working on this project, identifying pediatric patient in EMS and all the heterogeneity that exists, looking at all the different protocols around the United States. So finally I'm getting ready to push that one into the public, which will be fun. I think the premise there is I'd like to see if I can get a critical mass towards having a discussion of, do we need to have a standardized age of pediatric patients in EMS? Because this comes up continuously. A couple times a year I'm on calls. I'm part of a national pediatric emergency medicine and EMS quality group right now. And you get wound around the axle immediately because there's so many definitions of what's a pediatric patient in EMS based on where you're standing.
Okay.
So
interesting.
Just working on that.
Right.
I'll keep you posted.
Okay. All righty. Well, it's maybe come up with the same definition like when I came up with the one for the elderly, right? So, hey, AJ, I apologize for cutting you off. I just wanted to make sure we were still staying on other things. But the other thing is, I had a secondary agenda on that, which is let's have it done next week, where you give it a better presentation, because you sound very excited about it. And I think it'll be good. And I'd rather give it a good, much better, not a rush job. And more importantly, get it out to a larger group, because a lot of people have fallen off. Is that okay then? Can you remind me to do that?
I put some notes over here so people can see it, but I think it's a game changer.
Okay, good. Well, then please then give us, let's give it a good full representation on that to a larger group next week and all that kind of thing. So, all right.
Okay.
Now, anybody on the phone want to pipe in and say anything before we get off?
Hey, Paul, it's Glenn Sater from New York City.
Yes, Glenn, go ahead.
Hey, I'm so sorry to bother you. Just, we're getting
You're
word.
bothering, yeah, don't bother me, Glenn.
We're getting word from our city DOH that CDC is potentially going to be filtering flights, people flying from Guinea and DRC to 6 airports in the US because of Ebola, potentially. I'm just wondering if anybody else has heard that. Then
Not
I
at
looked
all.
at I took a look at the a search, and it's like limited to like 9 and 8 confirmed cases in both countries. But I'm just wondering if anyone's heard of anything.
I actually this is the first I've heard of it, and then but let me ask you this. Let's bring it up on the call. I'll try to remember to do that. You're on the call in an hour, right? Are you gonna be able to make it?
You know what? It's not on my conference. It's not on my schedule.
Huh, it's not on your calendar, but okay, all right, I'll
Correct.
send the information to you, okay? So just
Yeah, the 6 airports don't seem to be posted anywhere yet.
okay, thanks, Crawford.
Yeah, no, I actually saw it potentially JFK, Newark, Los Angeles, Atlanta. I can't remember the other, Chicago maybe, and there were 6. I can't recall the other ones.
Okay, got it. So Glenn, I'll try to see if they drop your name off by accident. You should be on the call with us. I'll find out about that, and that would be a good thing to bring up with them. Okay, next week about it. I'll give them a shout right now and make sure you get. If not, I'll send you my information to get on. Okay. So.
Okay, thank you.
All right, good. And then that's right, John. It is like, isn't it like an hour from now or something like that? John Kramer with the CDC folks. I guess I might have lost him then in the meantime as well. Okay, well, all right. Well, I think that's it for me at this point in time. Anybody else want to pipe in with anything? That was really interesting. Thanks for alerting us, Glenn. So, all right. All righty. And then next week, Glenn and maybe Ken Shepke and some other folks, I want to talk a little bit about where we are. And of course, John, about maybe long haulers, because that's really getting to be the big thing. If I get back to David Slattery, for example, is that we're seeing a lot of the people are saying, oh, I'm young, healthy. If I get it, it'll be mild. But we're actually seeing the people with they're young and healthy with milder things getting much longer term, some chronic effects, sometimes subclinical at first, and that comes out later. So that's going to become a big focus of the NIH. I may want to talk about that a little bit more next week in some detail to get ready prepared for that. All right. Well, listen, thanks again, then. We'll talk to you all later on. Okay. Signing off. Back
hey, thanks, everybody.
To the show that never ends next week. Ben, go ahead. We're going to stay.
No, thanks, everybody. Stay safe. Very helpful. I appreciate it.
Good. I'm going to get you on next week, Ben, because I hadn't heard from you for a while, but thank you. You're always there, and I know it. So thank you so much, Rob.
Thanks, you guys. Thanks, Paul.
Meg, the usual. Okay. So thank you guys for being there. See you later. Bye-bye.